Good evening, all. Welcome to the continued medical education program on Retina by Jharkhand Ophthalmological Society. So today we have three speakers. So over to Dr. Sunil Kumar, the Rio RIMS HOD, for introduction of today's CME's speakers.
Thank you, ma'am. Thank you, ma'am. Am I audible?
Should we share the slide? Slide share karo to.
Yes, yes.
Slide share kariye.
So good evening, everyone. So now we will have the master class on the retina, and we have three speakers with us. So the first speaker is Dr. Shweta, and she will be speaking on OCT retinal disorders and FFA back to basics. She is from Jamshedpur. Next speaker will be Dr. Abhishek Pattanaik, and he will be speaking on ultrasound B scan of the eyes. Very, very important topic. He is from Jamshedpur. And Dr. Ritika from Ranchi, and she will be speaking on intravitreals in ophthalmology. So we will have the great speak on these retinal disorders. I think these are very basics topics, and this will be very useful for the PG and residents. So with this, without wasting time, I should invite Dr. Shweta for her first talk on OCT retinal disorders and FFA back to basics. So Dr. Shweta, please.
So you
Good
have
evening, everyone.
good evening. You have two talks.
Yes, ma'am.
Yeah. Yes.
Yes. Please.
Yeah. My slide is visible to everyone?
Yes, visible. Yes, very well
Okay.
visible.
So good evening, everyone. The first talk for today is on OCT, that is optical coherence tomography, and its usage in retina per se. So retina is divided into two parts, as you all must be knowing. The outer part, which is composed of the retinal pigment epithelium, and the inner part, which is known as the neurosensory retina. So the RP is the outermost layer of the retina, and it is a single layer of hexagonal cells, and it contains the pigments, that is melanin and lipofuscin, which is again used in what we call as autofluorescence. The neurosensory retina is the remaining 9 layers of the retina. This neurosensory retina is again divided into the inner retinal layers, the 6 inner retinal layers, and the outer 4 retinal layers. And namely, these are supplied by the retinal vessels and the choriocapillaries. So OCT is a non-contact, non-invasive technique for micro-resolution and cross-sectional imaging. This uses the light in the near infrared spectral range, and it has a penetration depth of several hundred microns and an axial resolution of 5 to 7 microns. And it works on the principle of Michelson's low coherence interferometry. So these are the OCTs, the progression that we've had over the years. First, we had started with the time domain OCT, and now we are on to spectral source OCT. But most places do have the spectral domain OCT. So the resolution of the swept source OCT is the best because it performs around 1 lakh to 4 lakh A scans per second. And the choroidal visibility is superior to the other OCTs available. So coming to the principle of what happens. So from the light source, there's a light which goes, okay, and this light is then split by a beam splitter. So the split light now is divided into two parts. One part goes to the reference mirror, the other part goes to the patient's eye. And from both these places, the beam that has gone is reflected back. And the machine detects what is the time delay between these two reflected beams. And that time delay is how the OCT is mentioned or is performed. So what is the international nomenclature of OCT? In 2014, an international panel of OCT experts had come together to come to a consensus on what is the proper terminology for the retinal layers. Okay. So now these layers are basically known as zones. Now we call them zones. So we'll go to that now. So based on the reflection of light, we have hyperreflective bands and zones, and we have hyporeflective bands and zones. So the hyperreflective bands are RPE, the external limiting membrane, the outer plexiform layer, the inner plexiform layer, the nerve fiber layer, the ILM, and the posterior cortical vitreous. And the zones that we define it as interdigitation zone and the ellipsoid zone. So basically the hyperreflective layers will be those layers which have fibers in them. And similarly, in hyporeflective bands, we have outer segments of the photoreceptor, the nuclear layers, the outer and inner nuclear layers, and the ganglion cell layer. And zones, we have the myoid zone. So the hyporeflective structures are the layers which contain nuclei of anything like the photoreceptors or the outer nuclear layers. So all layers with nuclei will be hyporeflective on an OCT, and all layers with fibers will be hyperreflective in an OCT. Okay. So this is how a swept source OCT looks like. So you can see the hyperreflective layers are the white layers going from the vitreous side. This is the posterior cortical vitreous. Then you go to the preretinal space. Then comes the first hyperreflective layer, that is the nerve fiber layer. Then the GCL, which is the hyporeflective. Then the inner plexiform layer, which is hyper. Then inner nuclear layer, outer plexiform layer. And then you go on to the outer retina, which has the the external limiting membrane, then the myoid zone, then the ellipsoid zone, the interdigitation zone, and the RPE. Okay. Below the RPE is the choroid, which is better visible in a swept source OCT. The choroid, namely, we have the three layers, which has the choriocapillaries, that is closest to the RPE. Then we have the sattler layer and the halar layer. So this is what the outer retinal layers I was talking about. So these are the hyperreflective layers in the outer retina that we have, starting from the external limiting membrane. Then we have the ellipsoid zone. Then we have the interdigitation zone. And then we have the RPE Brooks membrane complex. So going from top to bottom means going from vitreous side to RPE, we need to define any OCT of a patient using these layers. So why do we use an OCT in retina? So in any part of the body, if we need to do a histological section of any part of the body, it is easier to get a tissue sample, but it is not so for retina. You cannot get a retinal biopsy so easily. So the OCT is the closest that we have to a histological section. And as you can see the correlation, as you see on a histological section, very similar to that you have on an OCT. Okay. So the OCT is a very useful investigation for any retinal surgeon or any retina specialist who has to diagnose a disease, treat a disease, and prognosticate a disease. So what is the applied aspect of OCT? So we see the change in reflectivity, whether any lesion is hyperreflective or hyporeflective. There is a decrease in thickness or increase in thickness, whether there is an abnormal deposits present, the morphology is altered, and then on the basis of transmission of light, we call hypertransmission, that is more transmission of light. So if any layer is absent, more light will go to the lower layers, the deeper layers. And shadowing is less transmission of light. If there is any structure which is blocking the light, it can be blood, it can be a drusen, it can be a hard exudate, that will block the light and will cause shadowing. So similarly, that's what I was talking about. What are the hyporeflective structures that we see on the OCT? It can be fluid. Now, fluid can be retinal edema, that is intraretinal fluid. It can be subretinal fluid, or it can be sub-RPE fluid. Okay, these three fluids are at different levels. And similarly, the hyperreflective structures will be hard exudates, any hemorrhage, an epiretinal membrane, a choroidal neovascularization. It can be below the retina or below the RPE, or it can be any drusen. So now coming to various examples. Now in the vitreous cavity, generally you will not see anything in the vitreous cavity unless there is a vitreomacular traction, that is a tractional membrane you will see over the fovea, which is causing a traction on the fovea. It can alter it or it can just remain the same. We can also have hyperreflective dots, which will signify a vitreous hemorrhage or an asteroid hyalosis. That is what I was talking about. This is the posterior cortical vitreous, which is normally not seen because it is either adherent or it has completely detached and it has gone up. Sometimes it is seen, as you can see in this picture. This is a picture of a posterior vitreous detachment, and this is a complete PVD that has happened. This is what I was talking about. Any vitreomacular interface disorder, it can be an adhesion. That means there is a perifoveal PVD with posterior cortical vitreous attachment within 3 mm of the fovea. However, there are no secondary changes in the contour or within the retina, meaning to say that the fovea contour is maintained and the retina looks more or like normal. Then comes vitromacular traction. Now, this is any vitromacular adhesion which is causing any distortion of the retinal layers, or it is causing a disturbed foveal contour. So in the picture, that the OCT picture, you can see that there are two membranes kind of thing which are pulling the fovea up, and there is a hyporeflective space just beneath that, so which is being caused by this traction. So this is what is vitromacular traction. Then the next thing comes is macular hole. Now, macular hole is a full thickness defect in the neural retina. That means the RPE is intact. However, the 9 above layers have separated and created a hole. So this is how a macular hole looks on an OCT. And using the OCT, we prognosticate whether it is a large macular hole, small macular hole. We classify it and tell the patient whether it can close spontaneously, or it will close after a surgery, or it won't close after a surgery. Next, coming to the next thing which comes in the vitromacular interface is the epiretinal membrane. This is a hyperreflective membrane which is present over the surface of the retina. How does it occur? It is a fibroglial proliferation, and this occurs secondary to a break in the ILM which occurs during PVD. So there are micro breaks through which there are glial cells and RP cells which migrate, and then they proliferate on the surface of the retina, causing this membrane to form. Next, coming to the nerve fiber layer. So as I mentioned, the first hyper-reflective layer in the retinal OCT is the nerve fiber layer. And normally it is thick in the nasal quadrant. And this is very important to note because that's how you identify where the disc is, and that's how you identify which eye the OCT belongs to, which will be helpful in the exams. So it can be, so now the nerve fiber layer can be thick due to cotton wool spots, because as we know that the cotton wool spots are axonal infarcts which occur in the nerve fiber layer, or it can be thin or lost due to ischemia like we have in vein occlusions. Now coming to the inner retina. So we've talked about the vitromacular interface. Now we come to the inner retina. So the inner retina is composed of the inner 6 layers of the neurosensory retina. So first coming to drill. Now drill means disruption of the inner retinal layers. So what happens here is there is no distinction seen between the inner retinal layers. If you see in the image on the left hand side, you can see very well demarcated light and dark bands. However, on the right side of the image, it just shows a homogeneous type of a structure. So this is what is drill. There is no distinction between the inner retinal layers, and this signifies a poor prognostic marker in any disease that is there. This, however, is a case of vein occlusion. Next, coming to hyperreflective. Now, what happens is when the retina goes to infarction, it becomes hyperreflective, and there's a diffuse hyperreflectivity. In the left image, you can see the inner retina is diffusely hyperreflective. This is a case of central retinal artery occlusion. However, when you see focal hyperreflective structures, now it can be inflammatory cells or it can be hard exudates. Okay. So how do we differentiate? We can see the size, or hard exudates will have backshadowing, whereas the inflammatory cells will not have backshadowing. So that's how we differentiate whether any hyperreflective dot in the inner retina is a hard exudate or is it an inflammatory cell. So here again, you can see these are clumps of hard exudates. You can see the left picture is the OCT picture. The right picture is the histological section. And very beautifully, you can see it's this almost the similar picture where you can see these lipid-laden macrophages here on the histology section, and you can see clumps of hard exudates on the OCT. What is hyporeflective? Now, hyporeflective, as mentioned, will be any fluid. Here you can see this fluid is in the inner retina, and these are cystic spaces due to fluid leak. So this is a central involving macular edema. Next, coming to the outer retina. So outer retina, what composes the outer retina is it is from the external limiting membrane to the RPE. So it can be hyporeflective due to loss of tissue or due to fluid, like there can be subretinal fluid or something, or there can be an ellipsoid zone loss. Like in this picture, you can see there is inner retinal edema as well as the ellipsoid zone seems to be lost. Just over the RP is the ellipsoid zone. Next, coming to the subretinal space. Now, the subretinal space is a potential space. Potential meaning this space is normally not seen. However, when it is seen, that means it is filled with either blood, or it is filled with a neovascular membrane, or it is filled with fluid. So, when does it appear hyperreflective? Whenever it is filled with a hemorrhage, or it is filled with a choroidal neovascular membrane, then it appears hyperreflective, like you can see in the left image. When does it appear hyporeflective? It will appear hyporeflective when this space is filled with fluid. Now, this space can be filled with fluid in case of a CSCR, where it will be a localized detachment, mostly subfoveal, or it can be a tractional RD, where there is a traction over the retina and the traction has pulled the retina away from the RPE, creating a space that is filled again with fluid. Next, coming to macular edema. Macular edema can present as a cystoid macular edema, or it can be a spongiform macular edema, or it can be tractional macular edema. Spongiform macular edema means there are many small spaces in the single layer, like you can see in the histological section. And tractional macular edema is something is pulling the macula up, and that is causing fluid to accumulate in the macula. So this is how macular edema appears on an OCT. Next, coming to the RPE-Brooks complex. Now, this is very important, as here the most important thing that we have to note is a pigment epithelial detachment. So there are 4 types of pigment epithelial detachments based on reflectivity. How do we differentiate all 4? Now, if there is a drusen, you will see a hyperreflective kind of a structure, and there'll be epithelial detachment. Whenever there is a pigment epithelial detachment, the RPE and Brooks will be seen separately. Normally, if you say we call it the RPE-Brooks complex, we call it so because the Brooks membrane normally is not visible. However, whenever there is a detachment, you can see the Brooks membrane very clearly. So in the top picture, that is a drusenoid PED, where you can see there is a hyperreflective structure and there the RPE has lifted up. Next, coming to serous PED, as the name suggests, it's serous. That means there is an epithelial detachment. However, it is filled with serous fluid. So whenever it is filled with fluid, as mentioned earlier, it will be hyporeflective. You can see in the second picture, in the middle picture. Then comes fibrovascular PED. Now, fibrovascular PED will have both hyporeflective and hyperreflective elements in them. Okay, like you can see in the third picture. So you can see the arrow, the yellow arrow points to the hyporeflective area. The asterisk, the yellow asterisk points to the hyperreflective area. So when you see this mixed reflectivity, you call it a fibrovascular PED. Now, hemorrhagic PED appears like a serous PED. It will appear like that. However, there will be backshadowing because the blood is preventing the light to go deeper. So you won't see the choroid beneath. So in the middle picture, you can see the choroid. So that is a serous PED. If we were not able to see the choroid, we would have termed this as a hemorrhagic PED. So that is all in short about OCT. So you have to mention OCT in 5 points. You have to mention the posterior cortical vitreous, the vitreomacular interface, how the foveal contour is looking, the inner retina, the outer retina, which includes the RPE-Brooks complex. Thank you. And if you have questions on OCT, you can ask. Any questions, or should I continue to FFA? Hello. Hello.
Thank you, Dr. Shubhra, for your elaborate explanation of optical coherence tomography in retina and the FFA in the ready for the FFA नहीं हुआ है ना अभी?
नहीं मैम.
तो शुरू करो उसको.
Okay, मैम. Okay, so next coming to fundus fluorescein angiography, which is another important investigation in retina. So I'll be going through basic principles, the technique, the phases of the angiogram, what is normal fluorescence, abnormal fluorescence, and the indications. So it is a technique in which we take a rapid sequence of pictures after injecting an intravenous dye. So the basic principle is luminescence. Luminescence means there's emission of light from any source other than high temperature. So basically, it is an inherent tendency of anything that it emits light. And fluorescence is you have to excite that particular structure. So luminescence, which is maintained by continuous excitation, constitutes fluorescence. Okay. So this structure will emit light of a longer wavelength when it is stimulated by a shorter wavelength. So what the dye we use is sodium fluorescein. It is a low molecular weight protein. 80% of it is bound to plasma proteins and 20% is unbound. And this 20% unbound part is what causes fluorescence and what helps us in the FFA. It is metabolized by liver and eliminated by kidney. So we need to check the kidney function test before going for an FFA. So the dose, the normal adult dose is 10 milligrams per kg. So the ampule that we have is either a 3 ml ampule of 20% dye, a 5 ml ampule of 10% dye, or a 10 ml ampule of 5% solution. The pediatric dose that we use is 35 milligrams per 10 pounds of body weight. And if the patient has a kidney disease and there is a necessity to do an FFA, we can also use an oral dose where we use 10% of sodium fluorescein, which is mixed with orange juice as 30 milligrams per kg. And the picture is taken, however, after 20 minutes to 1 hour in the oral dosage. So what is the property of sodium fluorescein? The excitation wavelength is the blue range, that is 465 nanometer, and the emission wavelength is the yellow-green. Basically, what this means is from the camera light source, white light goes. So we have a filter. So this filter filters out all the light except blue light. So the blue light goes to the eye. Now we've already injected the dye. This blue light sensitizes this dye that is there in the retinal vessels. And then this is reflected back. When this is reflected back, we have a barrier filter. This barrier filter blocks all the other light except for the yellow-green light, which is captured by the camera. So this is how FFA works. So it is a blue excitation and the yellow emission. So the procedure is, you need to explain the procedure by taking an informed consent, position the pupil, dilate the pupil adequately. First, color fundus photographs are taken, red-free photographs are taken, and then before the injection of dye, we do take some photographs to rule out any pseudofluorescence and autofluorescence. So what is pseudofluorescence? This occurs when there is the blue exciter and the green filters overlap. This occurs mostly due to an aging filter. So we need to replace the filter in the machine. However, autofluorescence is there are certain structures which emit fluorescence in the absence of the dye. So they are autofluorescent. That is their inherent character, like optic nerve head drusen or astrocytic hematoma. So these structures, even without the injection of the dye, will appear hyperfluorescent. That means they will appear white. So this fluorescing dye is injected in 4 to 6 seconds. We use a median cubital vein. Ideal injection time, as I told, is 4 to 6 seconds. We need to explain the patients about the reactions that can occur. The most common reaction is nausea. So you need to tell the patient that you will have nausea and inform the patient that there will be a color change of the urine and skin can happen. So, and we need to be prepared of the grave reactions that can occur. The patient can go into anaphylactic shock, can have seizures, and also can collapse at site. So the contraindications, the absolute contraindication is only one, that is an allergic reaction in the past. However, the relative contraindications will be cardiac disease, renal impairment, uncontrolled hypertension, and pregnancy. So it is a category C drug, although there are no reported birth defects, but we do take clearance from the OBGYN before doing FFA if necessitated. So this is how the dye goes from you inject it, it goes to the internal carotid artery, goes to the heart, the arterial system, then the internal carotid artery, ophthalmic artery, and then it goes to the choroidal circulation and the central retinal artery. So the choroidal filling is 2 seconds prior to the retinal filling. So now coming to the phases of the angiogram. So first phase is the choroidal phase. Now this phase is known as the choroidal flush. This occurs due to the choroidal filling. This occurs before the retinal filling. So this is the time when we have this patchy choroidal filling in the background. You will see patches of black, patches of white that is occurring because the choroid is getting filled. Sometimes you will see an artery getting filled just temporal to the disc, that is the cilioretinal artery. The cilioretinal artery, even though the name has retinal in it, but it is supplied by the choroidal vessels, so it fills in the choroidal phase. Next is the arterial phase. This occurs 1 to 3 seconds after the choroidal filling, and this is the complete filling of the retinal capillary bed. You can see in the picture the arteries have filled. And then we come to the AV phase. Now the dye is moving from the artery to the veins. This occurs to the 13 to 14 seconds of the exam. So early you will see laminar flow. Now what is laminar flow? You can see here the vein, the vessel, the wall of the vessel is stained white, while the middle of the vessel is still black. So this is what laminar flow is. This signifies an early AV phase, and the late AV phase will be where the entire lumen will fill. Then we come to the venous phase. Again, the dye is progressing further. Now it is going more into the vein. I mean, it is draining more from the vein now. This is 15 to 20 seconds. You can see full-filled arteries, full-filled veins. This is the venous phase. So fluorescence will decrease in the arteries, will increase in the veins. And this is the time where you will see the foveal avascular zone very clearly. The foveal avascular zone will be seen as black, which I'll explain later why. And this is the recirculation phase, which is the late phase. This occurs where the intensity of the fluorescence will slowly diminish as the dye eventually is eliminated from the kidney. So now this is the foveal avascular zone. Now what happens is this is the perifoveal capillary free zone. Now this is there you have xanthophylls. Now this xanthophyle will absorb the blue light. Hence this appears dark. Again, there are tall RP cells here. So there is increased RPE pigment. So these tall RP cells block the fluorescence. So they do not allow the choroidal fluorescence to be seen. That's how we see the fovea as black. That does not mean that the choroid below the fovea is not being perfused. It just means that the fluorescence is blocked. So this is best seen at 25 to 30 seconds where we are already in the late phase. So how do we report an angiogram? We have things called hyperfluorescence, which means that it is appearing more white, and we have things that is hypofluorescence, that means it is appearing darker or black. So hyperfluorescence can be either due to more dye or it can be due to better visibility of dye. So more dye can be either the dye is leaking or it is pooling in an area or it is staining. And better visibility of dye means that there is some defect in the retina which is allowing the choroid dye to be seen very clearly. Hypofluorescence can be due to less dye again, which will be due to non-perfusion. That means there is an area which is being non-perfused, or poor visibility of the dye. Why will be the dye less visible? Because there is something which is blocking the fluorescence, which is not allowing the light to pass through. That's why it is appearing black. So now first coming to hyperfluorescence, the first instance is a leak. So now leak of the dye is occurring from the intravascular space to the extravascular space. This is basically there is a breach in the outer or the inner retinal barrier. So now in the leak, you will see that the hyperfluorescence, it increases in intensity and it increases in size with time. So both the intensity and size will increase. In the picture, you can see in the first picture, you see there are tiny hyperfluorescent dots at the fovea, which increase in size, okay, and intensity over time. So this is how a leak looks. So here you can see this picture. This is a color fundus photograph, and you can see how there is hyperfluorescence along the superiotemporal arcade. So this is a PDR. Again, this is a case of neuroretinitis below, where you can see there is hyperfluorescence around the disc. That means there is something leaking around the disc. This is disc edema. This is how disc edema appears on an FFA. Next, coming to the next case of hyperfluorescence, that is pooling. So pooling, as the name suggests, that there is something going into a well-defined space. Like you have a swimming pool, there is a well-defined 4 walls. Similarly, pooling means there's a well-defined space and the dye is leaking into it. So the intensity will increase, however, the size will remain same. This occurs in case of PED. So PED is a detachment of the RPE. So the dye will go to that detachment and will remain in that detachment. It is not going anywhere else. So the intensity will increase, however, the size remains same over time. Next is staining. Now staining occurs where because there is leak of dye into a tissue. Here again, the intensity will increase, the size will remain same. However, the intensity will over time decrease. Okay. So this occurs wherever there is a fibrous tissue, there is a scar, or there is retinal thinning, like you have chorioretinal atrophy. In areas like that, you will have staining. Next, coming to when I talked about more visibility of the dye. Now, I told that there is more visibility because there is a defect in the retina. So supposingly there's a macular hole. So no retina is there in the fovea because there is a macular hole. So you will see more of the choroidal fluorescence. So this is called transmitted fluorescence. Okay. So this is due to a window defect. So here the intensity will increase first, and as the dye washes out, the intensity will decrease. The size, however, remains same. Next, coming to things that have hypofluorescence. Now, first is blocked fluorescence. That means there is something that is blocking the light to, be captured by the camera. So it can either be any pigment, it can be a abnormal material, or it can be blood. Okay. So pigment like xanthophylls, that is in the normal foveal avascular zone, these block the fluorescence. Abnormal materials can be any hard exudate, any lipofuscin. If there is increase in the lipofuscin, like you have in Stargardt's disease, there is increase in lipofuscin in the RPE. So you do not have fluorescence in that. That's why you call it a dark choroid. You do not see the fluorescence because it is being blocked by this increased lipofuscin. Then the third thing is blood. Blood at any level. It can be a subhyaloid hemorrhage, it can be a subretinal hemorrhage, it can be a sub-RPE hemorrhage. All these three will block that fluorescence that is going to happen. So you will have a hypofluorescence in the retina. Okay. So now coming to reporting, how do you report on FFA? First, you always comment about the arm to retina time. Arm to retina time signifies that there is no blockage in that arterial system that I talked about earlier. This will be helpful whether in cases when there is an ophthalmic artery occlusion or there is basically when there is an artery occlusion. So first you mention the arm to retina time. Then you mention about the phases, all the phases, the choroidal flush, the arterial phase, the AV phase, and the venous phase. Then you comment about the foveal avascular zone, whether it is normal, it has enlarged, whether there is an edema in the foveal avascular zone. Then you talk about any abnormal fluorescence areas. This is the point where you talk about any areas which have blocked fluorescence, like due to uh, non-perfusion or due to blood or anything. So you talk that there is a hypofluorescence seen in the superotemporal quadrant, or there is a hypofluorescence seen around the disc, or things like that. This is the area where you talk about microaneurysm, that tiny hyperfluorescence dots seen around the macula, or tiny hyperfluorescent dots seen along this vessel, or whatever vessel you want to talk about. And in the late phase, when you have leakage and staining of the disc, you talk about there is a hyperfluorescence seen along the inferotemporal arcade, which increases in intensity and size. As soon as you mention it increases in intensity and size, the person who is reading the report knows that there is a leakage, so we need to tackle the leakage. So coming to the indications, as we all know, this can be used in a multiple retinal diseases, in diabetic retinopathy, in any vaso-occlusive disease, in ARMDs, in CNVM, CSCR, you name it, and you can use an FFA. So diabetic retinopathy, from mild NPDR to a PDR, you can use FFA to classify the disease, to prognosticate a disease, and also to tell the patient that your disease now is at this stage. We can do this later, and serial follow-ups yearly or something, and we can show how the disease is progressing. So this is mild NPDR that I was talking about. You can see these tiny dots. These are microaneurysms that are seen. The red arrow signifies that. Severe NPDR, you can see this black area. These are the areas of non-perfusion that I was talking about. So while mentioning in the FFA report, you mentioned that there is a hypofluorescence area seen in the macular area, suggestive of non-perfusion. Okay. In proliferative diabetic retinopathy, again, you can see, if you see the fundus photo, it cannot be clearly seen whether it is a PDR or not. However, when we do an FFA, you can see clear leak at the disc and clear leak along the superotemporal quadrant. So that's how you define it, that there's a hyperfluorescence which is increasing in size and intensity, suggestive of a leak. कुछ बचा नहीं है लगता है. Diabetic maculopathy, diabetic maculopathy includes two things. It includes macular edema and it also includes macular ischemia. So if there is macular edema, that means there is space in the retina. So the dye will keep filling and you will have this whitish, diffuse kind of a fluorescence there in the fovea. That is macular edema. And if it is macular ischemia, you will see that the foveal avascular zone has enlarged in size. That means the black area has increased in size over the fovea. Vascular disorders, again, I talked about. If there is a vein occlusion, you will see that there are, the veins will not be filling. As you can see in the fourth picture, you can see that the vein is clearly, black in color. That means it has not drained at all. It is blocked. Similarly, to differentiate between ischemic and non-ischemic venous occlusion, here you can see large areas of hypofluorescence. That means these are non-perfusion areas. You need to treat this patient with a retinal laser. Here you can see large areas of hypofluorescence, non-perfusion, okay? So this is a ischemic venous occlusion, okay? So you differentiate between ischemic and non-ischemic based on FFA. Artery occlusions, if the artery is occluded, it will not fill at all. So here you can see there is just a small area along the superiotemporal arcade which is still, viable. So you can see the filling there. Otherwise, all other vessels, you can see it is totally black. CNVM, again, there will be two types of leakage in CNVM. If it is a type 2 CNVM, it will have a classic leak. That means it will leak in the early phase. And if it is a type 1 CNVM, type 1 CNVM is which occurs below the RPE. So if it is below the RPE, there will be less fluorescence seen. So it is an occult CNVM, not very clearly seen on FFA. That is about it. So these are the most common indications that we do in FFA for. We also do it for CSCR, central serous chorioretinopathy, where you see the ink blot leak or the smokestack pattern, and we do a laser accordingly. So if you have any doubts or any questions, you're free to ask.
Thank you so much, Dr. Shubhra.
Yes, ma'am.
The first time you joined us and did
Yes,
very so. Thank you so much. Now over to Dr. Abhishek Pattanaik for ultrasonography in retinal diseases. Dr. Abhishek.
Yes, ma'am. Good evening. I'm just joining.
Dr. Abhishek for his talk. Please show your slides. Dr. Abhishek, am I audible?
Yes, ma'am. You're audible, ma'am. I'm just uploading my slides.
Okay. Hello, Dr. Abhishek. Should we take Dr. Ritika first because he's unable to share his slides? Dr. Ritika?
Yes, ma'am.
He's unable to share his slides, so you can present first.
Yes, ma'am. Dr. Ritika can go ahead, ma'am. I'll just try to upload my slides.
And go ahead, we are waiting.
Yes.
Yes, we are waiting.
Ma'am, are the slides visible? Sir, are the slides
No,
visible?
no, Shubhra. The slides are not visible.
Okay, 1 second, sir.
हाँ हाँ नमस्ते
Sir, 1 second. Hello. Sir, now?
Yes, the slides are visible.
Okay.
मैं क्या कर रही हूँ is visible please go ahead
Okay.
go ahead
Thank you, ma'am. So, Shubhra, you have to help me in changing the slides.
Yes, sir.
Thank you, Dr. Bharti Kashyap, ma'am. Thank you, JHOS, for giving me this opportunity to join this webinar. So, good evening, dear colleagues and dear students. After a long, hectic day, we are here with another short topic. I'll make it as short as it can be, but it should be clear to you all. It's an interesting topic, but we can't go too much elaborate in this, more of a practical thing. So what is ultrasound? Ultrasound, anything which is beyond the range of a normal sound that a person should perceive. So where this principle has been used to use as a tool, a diagnostic tool to delineate some retinal disease. So we can, this actually principle has been had from the bats, the habit that bats have. They are supposed to be blind, and so to locate their prey or any obstacle while they are flying, they generate some ultrasonic sound waves. And when the sound waves are hitting those prey or the obstacles and coming back to them, they try to detect them. So this principle was hired from these people, this bats, and it was applied on the human body in the form of ultrasonography to the abdomen or used in the eye. So this is some frequency that is too high, very high, like 20 megahertz or 20 kilohertz. And this, when used in the eye in a digitalized computerized technique, it helps in delineating some ocular pathologies. Generally, it is of two types, A scan and a B scan, and B scan denotes brightness scan. So what is the principle of this ultrasound in eye? It's a reflection of a high frequency sound waves when emitted, and when it touches the tissue interfaces with different acoustic impedance, then they produce echoes. And these echoes are generally captured and amplified into images, and then it is used to do the proper diagnosis. So it's acoustic wave which consists of a oscillating particle with frequency of more than 20 kilohertz. This is inaudible high frequency waves, but it is helps in resolution of the scan tissue because with high frequency they have a low wavelength, and if they have very high resolution and helps in giving a proper image. So when they pass through a medium or a part of it is reflected as echoes, are created and acoustic interface are created by the function of the media with different sound velocities. So when the difference is too high, then we get a stronger echo. And these echoes are generated with the help of a pulsar when it stimulates the probe or the transducer or the instrument that we use to do ultrasonography, some piezoelectric crystals are present on the probe. And when this is stimulated, they produce some sound waves, and this is converted into electrical impulses to generate this ultrasound waves. And they are again captured by the same transducer after they hit the um, parts in the orbital area. And when they're returning back, they are amplified into images, and then we get scans such as A scan and a B scan. So as earlier mentioned, A scan is a picture that this picture of a scan is a single wave or a single dimension acoustic display in which echoes are spotted as vertical spikes, which represents the time it takes to reach an interface. So the distance between two spikes provides an indirect measurement of tissues like the eyeball length, antechamber depth, lens thickness. The height of the spike indicates the strength of the tissue and sending back the echo. The cornea, the sclera, the lens send very high amplitude spikes. Vitreous membrane and the vitreous hemorrhage, if it is present in the vitreous cavity, send low amplitude spikes. Now this is a picture of the B scan. Okay. Now the B scan produces a two-dimensional acoustic section of the eyeball. Now echo is a representation. Echo, when it is produced with the help of a B scan, it is represented by a dot. And if the echo is too high, then the brightness of the dot is high. It requires a focus being with around 10 megahertz frequency to get this kind of a B scan. Now the B scan has got three orientations, that is transverse, longitudinal, and axial. B scan are combined together. They are echocardiography, which are done in our routine clinics. So this is a type of the scan that are generally done in our OPDs. So when we have some pathologies that is undetected through our fundus examination or slit lamp examination, we generally have a corneal opacity, or we have a vitreous hemorrhage, or vitreous opacities are there, and we are not able to come to a conclusion. And so this ultrasonography can come as a help to us to locate any kind of diseases. So as I told you, the probe that we use for doing the ultrasound, it has to be placed in certain positions over the eyeball. When we are going to do this kind of examination, then we actually ask the patient to get relaxed. We explain the procedure to the patient. We make the patient sit or slide down as whatever is convenient to the patient. Generally, we make the patient to sit in our OPDs, and we try to do the B scan. We try to put a hydrogel coupling liquid over the probe so that we get a good intensity of echoes. And we ask the patient to close his or her eyes and to look straight and put the probes in certain positions to get different types of scan. So as I mentioned, there are three types of scans based on the position of the probe that we are going to put. The first one is the transverse scan. As you can all see, the probe or the marker, there is a marker over the probe which we can which is depended as a dot in the figure. This marker is considered as present on the 12 o'clock part of the probe. So this probe, the portion of the probe in this kind of transverse scan is parallel to the limbus. So you can see how the orientations of the scan are. And based on the scan, you can just imagine how the waves are passing through the eyeball and getting reflected back. So this transverse scan is generally placed parallel. As you can see in this figure, the marker over the probe is parallel to the limbus of the eye. We come to the next scan, that is a longitudinal scan, where the probe or the marker of the probe is placed perpendicular to the limbus. So as you can see, all the orientations of the probe in this kind of scan is perpendicular to the limbus. So accordingly, we can imagine the rays passing inside and coming out, and we can always try to locate the pathology of the disease in the retina or the vitreous cavity. Axial scan. So here, as I mentioned you, the longitudinal scan, the probe has been placed over the eyeball, and the marker on the probe is perpendicular to the limbus. Now this is the next scan, or the axial scan. Here the scan position is very commonly placed by all the PGs in our OPDs, or I'm sure that you also must be using it. This is one of the types of scan that we do, and it's an axial scan where we are placing the probe directly over the eyeball, and where the patient is asked to see straight with his eyes closed or open, depending on how comfortable he or she is. And here the probe position is just straight on the coronal action axis of the eyeball. Here, when we are taking a vertical scan, we place the probe directly over the eyeball, and the probe marker is at 12 o'clock position. And whenever taking a horizontal scan, we try to place the marker of the probe toward the nasal side. So we come to next slide, where the indications of B scan. Generally, where do we go for a B scan to the patient? Generally, we have a very good, whenever we have got a good clinical slit lamp examination or fundus examination, we are through and through to some retinal diseases, but there are certain sections, certain times when we have difficulty, where there's a media haze or corneal opacity is there, or dense cataract we have in our OPD patients, that we go for opt for this kind of ultrasonography B scan. So whenever there is a opaque ocular media, like in the anterior segment, we have a severe lid edema or partial or complete tarsorrhaphy in a patient. We have severe corneal opacity, total hyphema or hypopion, pupillary membrane are present, or if we have a very mature cataract, dense cataract, which does not allow to have a good fundus view. In posterior segment pathologies, whenever there is a dense vitreous hemorrhage or inflammation is too high, and we are suspecting some any kind of posterior vitreous detachment or endophthalmitis, in those cases, this ultrasonography really helps to our conclusion. Whenever there is clear media, like in anterior segment uveitis or cyclitic membrane, then this helps us to distinguish if it's actually a the opacities that are present in vitreous cavities are actually due to any kind of vitreous inflammation or any vitreous hemorrhage. So this scan comes to play here. Any kind of intraocular foreign bodies or this evaluation also helps. We can take help of ultrasonography B scan. So this is this kind of diagnostic tool is generally more of a clinical based study in our patients, rather than just teaching you the principle of how it works and how the picture looks. So these are some examples that I have collected from our OPD patients, where you can see in this first picture, it's a case of a vitreous hemorrhage where media opacity is too high to know how the retina is it intact or not, and what is the extent of the vitreous hemorrhage, or if this vitreous hemorrhage is really present or not. Here, as you can see, no, Shubhra will go to the previous slide. So this vitreous hemorrhage, thank you, Shubhra, for helping me out. So vitreous hemorrhage, we see whenever we are doing a ultrasound B scan, then we get a multiple echogenic points of vitreous opacity. This echogenic spots may be a low to moderate brightness. If it is a very fresh vitreous hemorrhage, then we get a very low to moderate kind of vitreous echos. If it is a resolution, if the resolution has started to happen or clumps of vitreous hemorrhage have started to form, then maybe we get a very hyper echoes in those. But they have to be corroborated with the A scan also, where we get a low to medium hyperepletic spikes, which may be present in 10 to 60% of patients. Now, there's something called hastrode hyalosis that you would have come across in your slit lamp examinations in OPDs. So these are multiple dense mobile light points which are hyper echoes actually, and they have a posterior isoleucent area also that separates it from the posterior segment of the part of the eyeball, that is from the retina. There is a clear area of vitreous between posterior boundary opacities and the posterior. This is the distinguishing feature that we get in astrohyalosis, and how we can distinguish from the vitreous hemorrhage. Vitreous hemorrhage is very diffuse. There is no isoleucent area or any demarcation area that is present between the opacities and the retina. But here we get a clear area of vitreous between the posterior boundary opacities and the retina. Medium to high refractive echo spikes are present on the A scan. Endophthalmitis, extremely important cases that we generally ultrasound is really going to help us in diagnosing or coming to confusion, more close to our confusion of endophthalmitis, as they have almost a similar representation as a vitreous hemorrhage. In the vitreous cavities, we get very low to moderate echoes. We have got a, but apart from that, even if it has got a low to moderate echoes, just similar to vitreous hemorrhage. But here, what we need to corroborate our clinical findings, also slit lamp examination findings, also along with the B scan findings. If the we in those cases in which we are suspecting that endophthalmitis is present, we have to be very much accurate in our diagnosis to a B scan, because the endophthalmitis spreads very rapidly, and we need to keep on delineating the layers that is getting involved. Even if the posterior segment is involved or the choroidal layers, choroid gets thickened, then we get a thickening of this RCS complex, that is retina, choroid, and sclera complex. If the endophthalmitis further advances, then we sometimes get a inverted T sign where the subtenon fluid may be present. And in further complicated cases, there is some traction RD also may be associated. So chain of low amplitude spikes are present and low intensity vitreous echoes are present, just like vitreous hemorrhage. But we need to corroborate with our clinical findings where the patient may be complaining of pain or anti-segment inflammation also. Posterior scleritis is a kind of extension of the endophthalmitis, as I told, and characteristic of presence is of this T sign where we get a subtenon fluid present, which gives an appearance of a inverted T sign. This is a very interesting ultrasound picture in suspected drop nucleus patients when we are doing our cataract surgeries, and uh, inadvertently some complication happens and PC rent happens, and nucleus gets dropped, or intraocular lens get dropped, or a part of the nucleus gets dropped before implantation of lenses also. Then that point of time we need to check what is the extent of like when their cortex drop or nucleus part drop or IOL drop inside the vitreous, and this ultrasound comes handy in this by giving a oval spot appearance, and which gives a high reflective spikes in the A scan. So let me just remind you once more, whenever we combine this B scan and A scan together, then we call it echocardiography. So most of the OPDs use both of these, so that the B scan pictures and the A scan can be collaborated, and so that it comes to a gives us a more clearer picture of the kind of pathology that we're dealing with. Retinal detachment, another most important finding that we generally use to confirm that it's what kind of retinal detachment, or even if retinal detachment is present or not. So this retinal detachment is actually appears to be smooth, folded, or mostly open or closed funnel sheet with insertion at the disc or the ora serrata. They give a very high reflective echo spike that persists even with lower gains. And they have a limited after movements. Whenever we ask the patient to move their eyeball, keeping their eyeball closed, then the movement of this membranes are restricted, and they don't keep on have some undulating movement, which I'll be discussing in other pathology. This is a tractional retinal detachment generally found in diabetic or severe diabetic retinopathy patients, where the membranes generally here also they don't have too much after movements, but the appearance of the membranes are tent-like or tabletop configuration. They also give high reflective echo spikes, which generally persist even with lower gains. This is another very common pathology that we need to know, which we need to distinguish from the retinal detachment. Many students or many PGs aspirants get confused with the retinal detachment and PVD. PVD is posterior vitreous detachment. The membranes appear here also, but the appearance of membranes are generally smooth. They're open funnel with or without their attachment with the disc or fundus insertion. They have a marked after movement. So here, whenever the membranes are very undulating, they have very rapid after movements. Whenever we ask the patient that to move their eyes upwards or backwards, then the movements of these membranes are very high. and we can distinguish from the retinal detachment as the opto movements are very restricted in those cases. So here also low to high refractive echo spikes are present. And the next slide gives you a differentiation between the retinal detachment and PVT. This is a very important question for your clinical practice. So in retinal detachment, the membranes are having a high refracting membrane, which are very moderately reflecting in posterior detachment. Generally attached to the optic nerve head, retinal detachment membranes, but in posterior detachment, they may or may not be attached to the optic nerve head. Retinal detachment, even if we reduce the gain, generally we keep a gain of 80 to 90 or 100 in doubtful cases. When we reduce the gains, although the spike remains the same in retinal detachment cases, but they may disappear in low gains in posterior detachment. They have a limited mobility in retinal detachment, and after movements on kinetic scan is limited. But in posterior detachment cases, they have a good mobility, and after movements on whenever the patient is asked to move their eyeball, that is called a kinetic scan or moving scan. The reflectivity in retinal detachment is uniform all over, but whenever we are dealing with a posterior detachment and we go towards the periphery, then the reflectivity decreases. This is another picture of a scan that is a choroidal that depicts a choroidal detachment. You can see thick, smooth, and dome-shaped appearance of the choroid. We don't have a disc attachment here. They are high. They have a high reflective double-peaked echo spikes also in the A scan. Uh, Whenever we are dealing with the intraocular foreign body, we have a very bright signal that persists on low gains also, and they give a very high reflective A scan spikes. So these were some pictures that I collected for the OP from the OPT patients for your understanding. So to summarize, ultrasound is a sound that is higher than the human audible range. Generally, we use 20 kilohertz, 20 megahertz of frequency in this kind of diagnostic tool, so that it can generate the echo that when hits a tissue interface in the eyeball, then it can generate certain echoes that can be amplified into images and can be reprinted on the scan. And it is one of the diagnostic tool, but it is not the only diagnostic tool that can delineate retina pathologies. And it has to be corroborated with other clinical findings and other diagnostic tools that is available for retina pathologies. So this was a very short topic, a short talk that I gave you students. So any questions you are having, you can just definitely ask me.
Thank you so much, Dr. Abhishek.
Thank you, ma'am. Thank you so much.
The entire Jharkhand Ophthalmological Society's residents and the ophthalmologists. Now I request Dr. Ritika. Are you here, Dr. Ritika?
Yes, ma'am. Can you hear me?
Hello, am I audible? Dr. Ritika?
Can you hear me?
Yes, you are
Okay.
audible.
Okay.
So she's going to speak on intravitreal injections. So,
Antibiotics to be specific.
Dr. Ritika?
Yes, ma'am. A very good evening to everyone present here. The talks have started from being lengthy and discussion based to just the right length to then short, shorter, and now comes the shortest topic of today, that is injections intravitreals. And I will share my screen. Is it visible to all of you?
Yes, yes.
Okay, ma'am. So the topic for today was intravitreal injection anti-VEGFs, an overview. See, there are a lot of intravitreal injections that you can do inside the eye, but the most common intravitreals that we do inside the eyes in ophthalmology is always the anti-VEGFs. So let us have a brief overview of the available anti-VEGFs that we know of. Let us start with the most humble anti-VEGF, bevacizumab. It is actually a recombinant full-length humanized antibody that has both Fc fragments and the Fab fragments that you know of. And Avastin, as you know, is the prototype. It was used initially for the treatment of colorectal cancers in 2004. And it was noted to be very useful as an intravitreal treatment in ophthalmology. If you go for the indications, every indication possible in ophthalmology, Avastin can be given. It's starting from diabetic macular edema, proliferative retinopathy, neovascular ARMD, myopic CNVMs, APROP, as well as neovascular glaucoma. You name it and you can do it. That is the safety of Avastin, and that is the productivity that Avastin has shown in every possible condition. But unfortunately, this beautiful drug is still off-label because of its bigger size and because of its slight systemic complications, that is acute rise of blood pressure, a small chance of myocardial infarction, stroke, and very rarely death. Like in our practice, we haven't seen any of these later indications happening, like MI or stroke or death. We haven't seen these things happening with our patients. Sometimes we do see acute rise of blood pressure after injections of intravitreal Avastin. And where you can give your injections, either in the operating rooms or in office settings. Both have been practiced all across the world, but the most common setting that everyone prefers is an operating room because it has significantly lower risk of endophthalmitis. I will come to details of bevacizumab versus the other injections in later slides. Coming to ranibizumab. Now, ranibizumab is a more purified version of the bevacizumab molecule that was finally FDA approved for intravitreal use. So it is basically a humanized monoclonal antibody fragment. It's a Fab fragment, FAB, that binds to and inhibits vascular endothelial growth factor A. Now, ranibizumab is more specific for VEGF-A, whereas bevacizumab binds all isoforms of VEGF. But of course, the most common isoform that you see inside the ocular surface is VEGF-A, and to be precise in that, VEGF-A 165. So indications of ranibizumab, again, it cover all spectrum of Avastin, that is CNVM, ARMD, myopic CNVMs, PDR, DME, APROP, it's an off-label use, neovascular glaucoma. So wherever Avastin can be used, again, ranibizumab can be used. Approved dose, it comes in either two doses. Either you can do a 0.3 milligram or a 0.5 mg. So 0.3 is specifically reserved for diabetic DMEs, whereas 0.5 goes for CME associated with retinal vein occlusions. And there was a lot of trials. I will name the most important trials in the very short, what it resulted in. The RISE and RIDE trials, they allowed FDA approval of ranibizumab for treatment of diabetic retinopathy in the presence of DME. Later on, FDA even approved it for the treatment of PDR without any DME. Anchor trials, that was ranibizumab versus verteporfin, specifically for cases of classic CNV, and Marina trial, where occult CNV was examined in ranibizumab versus sham injections, were 2-year multi-center double-blind studies. They evaluated the efficacy of 0.3 mg and 0.5 mg doses of intravitreal ranibizumab for the treatment of NAMD. Now, Bravo, it was basically for BRVO, and Cruise, it was for CRVO. You can see B for B and C for C. It's easy to remember that way. They were again 2 multi-center trials, sham-controlled and double-masked, that evaluated the efficacy of 0.3 and 0.5 mg doses of intravitreal ranibizumab in patients with macular edema following RVO. Radiance study was done to show that ranibizumab provided better visual acuity gains compared to PDT up to 3 months in myopic CNV cases. Aflibercept, still a better molecule than both bevacizumab and ranibizumab because it's a humanized recombinant fusion protein. It's actually a soluble decoy receptor. We call it decoy because instead of binding to the, it binds to the body's native receptors with greater affinity, then it allows the VEGF-A and VEGF-B and PIGF to bind to it. So it's like it acts as a VEGF trap. Approved dose is 2 milligram in 0.05 ml. But now, I think in April itself, they are going to launch this high dose aflibercept, Eylea HD, which has an intravitreal injection dosing of 8 milligram in 0.07 ml. It was approved in 2023, but now it's going to launch in India for wet AMD, DME, and DR. Estimated half-life of aflibercept is around 7 days compared to intravitreal half-life of ranibizumab and bevacizumab. So again, this is the reason ranibizumab is considered to be safer in cases of heart patients, because the half-life is less and it can be easily metabolized from the system. So the serum concentrations become very low to cause any untoward myocardial effects. Aflibercept is currently the only FDA-approved agent for retinopathy of prematurity. The newer drugs that have come, one is brolucizumab. You must have heard very well about it. Paganax, the most common name that you hear. It's also an anti-VEGF growth factor agent, but it is just a single-chain antibody fragment, even smaller than ranibizumab, exactly half the weight of ranibizumab. Recommended dose is again 6 milligram in 0.05 ml. These doses are important. Brolucizumab has a very good drying effect. So it was compared with aflibercept in Hawk and Harrier studies, and non-inferior vision gains were noted. So higher than expected. The only important side effect that brolucizumab has shown and is a reason for concern is the higher than expected incidence of intraocular inflammation. So retinal vascular occlusions and vasculitis, they have been reported in a much higher incidence than the other anti-VEGF agents. And the most worrisome thing is that you cannot predict with which dose you are going to have this. It can be with the first dose, it can be with the second dose, it can come even after 4 doses. And there is no way you can predict the safety for this. That is why one has to be very careful when one is using this drug in a one-eyed patient. Like, it is always considered better to avoid these kind of drugs in a one-eyed patient. So yeah, that's what I mentioned. The rate of intraocular inflammation every 4 weeks, if you inject brolucizumab every 4 weeks, it was 9.3%, which is quite high. So Novartis then recommended that after the initial 3 loading doses, you should not go ahead with any other dose with a less than 8 weeks gap. And suppose if the patient, you give brolucizumab and he develops, mostly they develop iritis and floaters, those are the most common complications. So they can respond very well to topical and subtenon steroids. But the rare cases, they sometimes even cause to lose your vision. Another one, faricimab, Vabysmo, as you know. Again, it's a combination mechanism medication with a simultaneous and independent binding to both VEGF-A and angiopoietin 2. Now, that is a way faricimab is more potent. It is having the same antibody configuration as the bevacizumab molecule, but because it works on both VEGF-A as well as angiotensin 2, it has found to be having stronger effects. It has been FDA approved for DME, NARMD, and RVOs. Angiotensin 2, it's an antagonist of tyrosine kinase. So once faricimab binds to the VEGF receptor, it even blocks the angiotensin 2 action. So what does angiotensin 2 does is that it causes phosphorylation and allows cytokine-induced vascular leakage. So the recommended dose of Vabysmo is again 6 milligram in 0.05 ml, administered by intravitreal injection. This is given every 4 weeks for the first 4 doses. Like, the initial loading doses are the first 4 doses instead of 3 doses with other injections. And thereafter, 12 weekly, you can give the injection based on the OCT findings of the patient. So here is just a pictorial representation. Now, this is a normal antibody. This is what you call the FC fragment, and this is called what you call the Fab fragment. So there are 2 Fab fragments and 1 single FC fragment. Now here you can see bevacizumab, it's a full antibody, 150 kilodaltons. Again, faricimab is also a full antibody with a similar 150 kilodaltons. And ranibizumab is a Fab fragment that you can see, it's 50 kilodaltons. Brolucizumab is a single chain Fab fragment. So there are 2 chains here. Brolucizumab is a single chain, shorter, and that's why it has a more potent action. Some important points to know. There is a protocol T in DRCR study, which compared the effectiveness of intravitreal aflibercept, bevacizumab, or ranibizumab for DME. Now that you know that for diabetic macular edema, all the three drugs are effective, which one to use and when to use. So the findings that were noted in patients who had a vision of 20/40 or better, the mean improvement in visual acuity was similar. Either you go with bevacizumab or ranibizumab or aflibercept. All three were equal. But who had vision of 20/50 or worse, the mean improvement was found to be highest with aflibercept, which was slightly more efficacious than razumab and bevacizumab. Additionally, the patients who were given aflibercept, they required lesser laser photocoagulation fewer times and allowed for more effective resolution of central subfield diabetic macular edema. Also, the incidence of arteriothrombotic events and death have been found to be similar for all the three medications. So this is prototype vascular endothelial growth factor VEGF 165. This is the VEGF receptor, that is the homodimer that you see here. This is the transmembrane domain. This is the proper VEGF receptor. And this is the intracellular domain, receptor tyrosine kinase. So when the VEGF 165 homodimer, this is like a heparin binding domain and the receptor binding domain. So when they come and attach to it, they cause a signal induction, which allows phosphorylation of tyrosine kinase and then cytokine-induced vascular damage. So this is what is being blocked by all the VEGF agents. Now come to the most important point, preparation for intravitreal injection. Preparation starts right from the time you see a patient inside an OPD. You know the patient is having a diabetic edema or a RVO or a neovascular AMD. You do a basic preparation, like you check for the vitals, the blood pressure, any signs of nephrotoxicity or myocardial infarction in the recent 6 months. That is very important to rule out, because if it is so, then you delay the injection of intravitreal anti-VEGF. Another thing, you check for the random blood sugar. I mean the basic things, and there is no infection, active inflammation around the eyes. When you take the patient inside the OT, the most important thing to use is the povidone iodine 5% solution drops. 3 minutes in the cul-de-sac of the conjunctiva eliminates most of the surface bacteria and makes it sterile enough to do an intravitreal injection with safety. Another important thing to note is that you should not talk while you are there to give the injections, because your oral flora contains microdroplets and they are found to be more importantly responsible for causing endophthalmitis when you're doing injections. You may think that you have taken all the aseptic measures, but if you continue to talk and if you are without a mask, those microdroplets can lead to endophthalmitis. Lastly, once you do the injection, always ask the patient, light dikh rahi hai? This ensures optic nerve perfusion. This is the most simple way. Other ways, you can also take an indirect ophthalmoscope and have a view of the retina immediately, so that you know that there is ample optic nerve perfusion happening. If you feel it's high pulsating, you can do a paracentesis, but most of the cases paracentesis isn't required. So these 3 points have to be very much taken care of when you do an intravitreal injection. Now, how do you give an anti-VEGF injection? Once you have given, the patient will ask you, ab kab denge? So there are 3 ways. Like Dr. Archana spoke about, treat and extend and pro-renata. Pro-renata is as you wish. Suppose the patient came to me, I saw him having an edema, I gave him an injection. Then the patient is gone. They may come, they may not come. Whenever they come, I will see. If I feel there is edema, I will inject. If I don't feel, I won't inject. There is no set protocol, no set follow-up schedule which has to be followed. Treat and extend is a protocol-based regime to follow for anti-VEGF. Here you give the initial 3 loading doses, monthly loading doses. Then comes the extension phase. Once the 3rd month is completed, you will call the patient after 6 weeks. So like you have extended the gap from 4 weeks to 6 weeks. Now when the patient comes, you don't just see him, you inject. You always treat and then extend. So this time when you treat, you will call the patient again after extended more 2 weeks. You will call him again after 8 weeks. When the patient comes back after 8 weeks, you again treat. That means you give the injection. So how much extension can be done? Extension can be done maximum up to an interval of 12 weeks to 16 weeks. Beyond that, you have to give the injection always. You cannot extend beyond 12 weeks. Suppose you can extend gradually and you could extend to a patient to up to 12 weeks. But call him again after 12 weeks and do treat the patient. That means he can continue with a 3-month gap. This is treat and extend regime. When to shorten the interval? If suppose the patient, you have called him after like 6 weeks and the patient returns at 5 weeks and he says that I have again having blurring of vision, you check the edema has recurred, you shorten up the interval. Instead of calling him like after 6 weeks, you call him up at 5 weeks next time itself. So that is treat and extend. There is another thing called wait and extend. Here it's the same thing, initial 3 loading doses, then you wait, you never inject, you wait till there is a reason to inject. In treat and extend, whether there is a reason or no reason, once you've extended that duration, you inject. So here the waiting time, if the eye responds well, suppose at 4 weeks, third injection is done, you call it 6 weeks. You feel macula is flat, no edema, wait. Call him again after 8 weeks. You extend it gradually. Again after 8 weeks, you see, again after 2 weeks, you call and see. So you have extended to 8 weeks now. If you see macula is dry, still no need to inject, call him again after 2 weeks. So maximum extension that you're doing is up to 12 weeks again with waiting instead of treating at every visit. So again, the maximum wait that should be done is up to 12 weeks. If the patient can be allowed to extend up to 12 weeks without injecting, the next time you call the patient is at again 12 weeks. Now come to the small things about the VRSI guidelines. You can read that on the VRSI website as well. So the most common way where we should prepare the Avastin injection, because that is the only multi-vial injection that we care about. The rest, everything comes in a single vial, so it's more safer. But there are a lot of patients in India who require injection Avastin or injection bevacizumab, to be very clear, because most of us are short on funds in India. So how do we fractionate an aliquot here so that we don't disturb the sterility? Like what you do, you take the vial and in a sterile OT, after scrubbing well and wearing a surgeon's gown and everything, in a sterile OT with a HEPA filter, you use a mini spike needle and you make aliquots of 0.2 ml in a tuberculin syringe and then cap it with 30 gauge needle. Now these prepared cap syringes, they must be stored in ETO sterilized pouches, which can be placed again in a sterile autoclavable container. And this box is to be kept in a cold chain at 2 to 8 degrees Celsius. This is well maintained. And two of the aliquots you send for microbiology and culture before you inject to any patient. Ideal guideline is to use it within a month. If at all something remains after a month, you better discard it. So last line, Avastin or anti-VEGF anything, it doesn't blind people. It's people who blind people. So small little maneuvers that you take care of and small little pointers that you take good precautions about will allow you to be more safe in your practice and to give better outcomes to your patients. Thank you. Hello? Ma'am, you're not audible.
Thank you, Dr. Ritika. Thank you very much.
Thank you, ma'am,
for your contribution to the society, for our ophthalmologists, and for the postgraduate students across Jharkhand. Thank you very much. We will keep taking your presentations and your guidance for the postgraduate students as well as the general practitioners also, and keep them enlightened with your vast knowledge in vitro retina.
Thank you, ma'am.
And because many a times it is very even for the general ophthalmologist, at least medical retina knowledge is very important. And nowadays there's so many general ophthalmologists also, they are giving intravitreal injections. They should be aware of everything.
Yes, exactly.
Yes. So thank you so much once again for today. It was a very, very lengthy evening. Academic event was a very, very lengthy event. Thank you so much.
Thank you, ma'am.